I'm an anaesthetic trainee in South East London, just returned to clinical training actually after 3 years working on the PQIP project team. I'm going to talk to you over the next kind of 10 minutes or so about a project that we've been doing over the last sort of year, 18 months or so, called POM VLAD, which stands for Postoperative Morbidity Variable Life Adjusted Display. So you will all know that there's a particular focus within PQIP looking at continuous reporting in terms of being able to monitor trends over time, particular focus on process measures, but we do also report some limited outcome measures that we collect within the PQIP dataset. So the plot on the right-hand side of the screen there is how we currently present postoperative morbidity data that we collect at day 7 by the 9 domains and colours related to the number of, or the proportion of complications. One of the downsides of how we're currently doing that is that there's no risk adjustment built into that. So we all know that outcomes are related to the risks that patients bring to their particular clinical episode, as well as the quality of care that they receive as well. So it's inherent that higher risk patients are more likely to have complications. Therefore, when you're trying to understand what is happening within your institution, building in some risk adjustment for those patients is important. This is what we've been trying to do as a small pilot project over the last year or two within PQIP. So this is how outcome data is often reported in national audit projects. So this is a funnel plot that's taken from the 4th National Emergency Laparotomy Audit. Essentially, each blue dot is a hospital. The curved sort of funnely lines below and above are 2 and 3 standard deviations either side. And if you look at just on the right-hand side over here where there's this blue dots out here, so the national average is just around 10% in terms of mortality. This hospital here has done about 425 emergency laparotomies in that 1-year series, and they sit pretty much exactly between those 2 lines. Now, if you're wanting to try and use this for quality improvement, it's going to be incredibly difficult because you've taken all of that richness of information of 425 laparotomies and you've condensed it down to a single point. The other thing that these charts tend to do is that you mask trends within the data. So because it's all down to a single point, what you can sometimes see is that a really good trend will mask a really bad trend. So over a 1-year period, you can have 6 months of good practice, 6 months of bad practice, and you end up sitting somewhere in the middle. So what we've been doing is using something called a variable life adjusted display, which was first published in 1997 and has been used quite heavily within cardiac surgery. Basically, it's a continuous plot. So here it is plotted by operation number, but you can plot it by date. And essentially, it plots the expected deaths minus the observed deaths over time. We've done it with morbidity rather than mortality. What you then see is that above 0 is effectively life saved, and below 0 is effectively excess lives lost related to the risk adjustment model that you're using. Then what you can see here is over this 550 case series, they have round about 27, 28 deaths fewer than would be expected by the model. So you can start to see trend over time. As I said, they've been used extensively in cardiac surgery, and this is just an excerpt taken from the recent case review of cardiac surgery at St George's Hospital in London. They've used VLADs within that report to demonstrate trends within the unit. Here they've used some confidence control limits, upper and lower. So upper is blue, 95% lower is the red, and you can see that over this period of time, the outcomes drifted down towards the lower control limit and then ran alongside the lower control limit. So you can start to see, as I said, that change over time. What they were very clear about saying, though, was actually on the VLAD plot over a short period of time, it doesn't give you an answer, it doesn't define poor practice, but what it's useful for is flagging up potential issues that then should be used and investigated to look into practice in a bit more detail, and actually say that over a short period of time doesn't constitute poor performance, but a well-governed department would use such a trend to further review outcomes. And that's very much what is borne out in the literature in terms of the use of continuous monitoring tools. The biggest implementation of VLADs to date has been in Queensland, Australia, as a response to the Bundaberg Hospital crisis, where a rogue surgeon was operating out of his competence zones and had a massively increased mortality rate and morbidity rates for his patients. So this was implemented in about 23 different outcomes across a range of medical and surgical specialties. Again, they chose to use some control limits on the VLADs in order to flag when hospitals, the variation in hospital practice had exceeded pre-specified limits. And then they had a different level of flag. So depending on what the outcome indicator was, if it was a really important one, like mortalities after elective laparoscopic surgery, laparoscopic cholecystectomies, then the response that was expected of hospitals flagging was different to if it was a slightly softer marker. And hospitals were expected to report back to either internally or increasingly, depending on the level of flagging, an increasing escalation towards central government. So what we've done within PQIP as just a small pilot kind of proof of concept study really is we developed a risk adjustment model based on about 4,500's worth of PQIP patients. We produced this dashboard which has 5 enhanced recovery process measures across the top that we felt were important looking back at PQIP data. And then this VLAD, which essentially plots major morbidity, major post-operative morbidity on day 7 using POMs and a subclassification of the POMs data that we collect. We piloted it into 10 hospitals in May 2018 and it ran for a year. We also identified 10 comparison hospitals which we'll use as a difference in difference comparison. So we are coming towards the end of a mixed methods evaluation of that. Essentially that means we're going to look at a whole load of quantitative stuff. We're also going to look at some qualitative outcomes as well, which have involved telephone interviews with 5 of the intervention sites, 5 of the control sites. 2 rounds of interviews, 1 at baseline and then 1 at follow-up as well, and hopefully some of these will help to inform possibly a wider rollout of this to the rest of PQIP. And as I said, the quantitative analysis will look at some of the process measures and morbidity as well. So we have some very preliminary results. Preliminary should be in bold and underlined with a few exclamation marks after it as well. But we've done a very brief difference in difference analysis. So essentially this says, well, if you've got a control group, so it's a way of analyzing non-randomized observational data. So you have a control group, you have an intervention group, and you have 2 time periods, so before and after the implementation, and it allows you to draw some comparisons between all of those. So we looked at pre and post implementation in, as I said, the 10 control and 10 intervention sites, and all in all we looked at just over 3,500 patients within those 20 hospitals. So this, just bear with me, it's kind of a bit statsy and slightly complex, but essentially the orange line here is the trend that you see in the controlled group, so the 10 control sites. So essentially pre-implementation here, post-implementation here. The green line is the intervention group, and the hashed green line up here is if the intervention group followed the same path as the control group, you'd expect it to end up here. The fact that it's ended up down here suggests that there's a non-significant potential slight trend towards a reduction in risk-adjusted morbidity, but it's non-significant in terms of 95% confidence intervals. If we look at the process measures that we reported, so the kind of 5 process measure bundle that we sort of highlighted was pre-op carbohydrate loading, warming intraoperatively, avoiding NG tubes in abdominal drains, and then getting patients drinking, eating, and mobilizing on day 1. Essentially, all of these were non-significant apart from the use of abdominal drains, which reduced in our intervention group. All of the other trends were non-significant. So I think that's where the qualitative evaluation potentially offers quite a lot, and we've heard from Duncan earlier on that the EPOC study, a lot of the work that's come, the qualitative work that's come out of that has actually helped to inform and understand what happened within the implementation side of things. And these are just some quotes from some of the interviews that I've done. So 24 interviews with various team members at each of the sites. And some quotes here. So some of the themes that have kind of come out of the data is that a lack of QI team structure and culture is a real barrier towards starting getting QI working in hospitals. We've heard about that already today a number of times. So this was a consultant surgeon I spoke to who said, we're pretty good at collecting data, but actually in terms of then using that data, well, that's much more complex and difficult, and we haven't really yet got going with that. From a research nurse, there's almost a bit of a disconnect that the research nurse is working really hard in an awful lot of sites to get that data collected. But actually, their role and what they're paid to do is to collect that data, but then actually they're not able to really act on it. And in terms of being able to feed back that data, many of the hospitals don't seem to have that formal structure of how they would feed back data. And from an anaesthetist here, just that QI is essentially, it's down to individuals, so it's down to the individual person to drive it. There's potentially an organisational push for quality improvement, but it's quite vague, not specific, and doesn't always link in brilliantly with PQIP. So this is something that we are aware of within the central PQIP team, and we are hoping possibly to be able to do a bit of work around some of these difficulties that you're all facing. As well as that, it's been mentioned already today and is kind of often the elephant in the room, is the lack of time that all of you guys have dedicated to delivering quality improvement locally. So from a research nurse point of view, the Trust is not hugely supportive of research. We're underfunded, understaffed and stretched, which I'm sure lots of you can feel the same. We're managing to collect the information, and actually that patients are really, this is one of the things that I think we should probably try and really reflect on, is that actually patients who are going through often some of the toughest times of their lives are being kind enough to provide us with their data to use, that actually we potentially, there's a duty of care to do something, to act on that result, to make things better for future patients. But actually that's difficult. It needs a lot of time, even to make small changes, and it needs somebody with a lot of motivation and a lot of time. And then also, we all have 101 different things that we're meant to be doing, so actually focusing on QI is very difficult. So I don't have any fixes for all of that. I apologise for any of those issues. So I'm just going to gloss over that fact and plough on. In terms of the future work that we've got planned with VLADs, so we chose initially deliberately to not include any control limits on the VLADs for various different reasons. They've been used elsewhere. As I mentioned, they were used in Queensland, they were using the George's cardiac report. And we've been doing some work to try and to look at different methods of adding and the best way of doing that. And I think we potentially might add some and try and trial that with a small select group of hospitals. As I said, we hope we might be able to roll a form of this out within the next year or so. We focus predominantly on colorectal surgery. We saw this morning that almost half of our patients recruited to PQIP are colorectal patients. So we focused on that initially, and the wider rollout is likely to just be colorectal, at least initially. And of course, although these might help you to pick up trends in morbidity more quickly, it's then what do we actually do with that result? So we're trying to develop some tools as well to help sites investigate where those changes, where there's problems, or good practice, equally as important, why that might be happening, and how they can spread either good practice or reduce some of the variation in poorer practice. And we're also going to hopefully improve some of the mechanisms that we have to share between trusts that are performing well, what they're doing and how they're doing that. Finally, just a big thank you to all of the sites, all of you guys out there that have been collecting data for this project. It's hugely, hugely appreciated, and also to those people that gave up the time to allow me to interview them when you're all very busy, and also to the Health Foundation as well, who funded this work. Thank you.